What has changed? If you're placed as a patient on one of our new units, which has an embedded hospitalist, you will be seen as often as needed by the same physician who's there all day long. As you see this physician, he will be working with your primary care physician, if you have a primary care physician, so they together can give you the best care possible. The nurses have easy access, as do the other care providers. They meet twice a day, typically on weekdays, once a day on weekends, to give you good communication available for you and your family. A hospitalist is a board-certified internist who is physically located in the hospital. Over the decades, life has changed for healthcare and medicine and physicians, where physicians who are working in the outpatient area are completely different than the inpatient area. The degree of sophistication has changed markedly. When I first started practice over 40 years ago, there were about 600 commonly used medicines. Now there's thousands and thousands of medicines. The hospitalist who is with you knows the care and treatment in the hospital, is familiar with the medicines, is available, and these folks are trained to take care of people who are pretty sick in the hospital. No longer are you admitted just for a, quote, checkup. Absolutely. We welcome and we want the primary care doctors to continue to work with the embedded hospitalist. Having a unit-based hospitalist who is available to the primary care physician, family, patient, all the time during the day makes a huge difference. So your primary care doctor, who's known you perhaps for years or even decades, is welcome to share information, share about your history, participate in the care. The metaphor I like to use is like having a coach on the sideline of a football game, sending the plays in and cooperating with the quarterback who's doing the actual play. The two together are much better than either one alone, and you'll get the best of both worlds. Has anything changed with specialists, cardiologists, orthopedists, other surgeons? Absolutely not. They still take care of patients. They're still working with you directly. You still get to choose whomever you want if you have a pre-existing relationship. And if they need a hospitalist, we'll have one readily available to help them with any medical problems that may occur during the hospitalization. We're following other hospitals around the country who've been successful with having embedded hospitalists and patient-centered care. What happens is we're good. We're not perfect. We've got a 5-star rating, which we're very pleased with. It's objective measures. It's not subjective matters. And we compare to hospitals across the nation, placing us at the current time in the top 7% of the nation, 4 others in Florida. We want to make sure that we stay at this level or do the best we can for the patients we care for. Every 6 months a new rating comes out, and everyone is getting better. Everyone's attention is turned towards objective metrics. So as we do this, we looked at other successful systems who are doing the same thing, having people dedicated to inpatient care, and we're doing just the same thing. What got us here won't get us there, and we do want to continue to be the best we possibly can be for our community and the patients we serve. Astoundingly good, surprising even to us. And the most important one, I think, is the fact that hospital-acquired conditions have dropped 50%. What happens with these units that are the pilot studies with patient-centered care is people spend 1 day less on average than they did before. So instead of spending an average of 4 days, they're down to 3 days. Well, if you spend a day less, you're less likely to fall out of bed, get a hospital-acquired infection, or have some other condition add to your sickness or illness while you're in the hospital. So the dramatic improvement on one of the units of a 50% decrease in hospital-acquired conditions, and we were already good, we were already better than the national average, has gotten even better. At our other unit where we have some long-term data and reliable data, it's gone down about 25%. Ultimately, we'd like to have no hospital-acquired conditions, but unfortunately, it's just not practical as people come in with certain things. In fact, in our community, about 8% of the people already have C. difficile, even coming into the hospital. But that's the primary motivation. The other thing that's happened, as I mentioned, length of stay, the time in the hospital's dropped about 25%, which is a big deal. And the patient satisfaction has risen, which has been a stumbling block for us for many years now. But now we're getting it better, and people are really liking this program very, very much. We're going to continue to collect the data, share it publicly, be completely transparent, and as success grows and we copy other successful hospital systems and healthcare systems around the nation, we're going to continue on with this. We've got a dedicated group of professionals. We want to be as welcome as we possibly can be to physicians in the community, and I think people are beginning to understand how good this is for patients, and we are very patient-centered. Interestingly, the emergency room has been like this for decades. Only the emergency room physicians are allowed to work there. Your primary care physician is always welcome to visit and work with the emergency room doctor, but in essence, in this case, the emergency room doctor is the quarterback, and the coach coming in from the outside would be your primary care doctor. Critical care has been limited to critical care physicians who are available 24/7 and take care of patients who are critically ill, which makes the point that hospital care has changed so much in the last few decades that outpatient care, with somebody admitting just a couple patients a month, less than 3 is the average for the primary care, versus a hospitalist who's admitting 10 or more patients per day, it's 2 different skill sets, 2 different knowledge sets, 2 different availabilities. Heaven forbid you should get chest pain in the middle of the day. Your hospitalist is right there, having to find your primary care doctor who is appropriately busy in his or her office. It's just hard to do. Change is hard. Some doctors are absolutely fine with this, and actually, interestingly enough, including many of the concierge doctors, have been doing this, working with hospitalists for years now, and having the hospitalists do the primary admissions and coming in and consulting and seeing their patients with the hospitalist. So it's an old program. Some of the other folks, for whatever reasons, and we'd have to ask them why they're so upset, but really, ultimately, if the patient's care is the center, decreasing hospital-acquired conditions and helping patients, I think that should trump everybody else's personal interests. Actually, this is expensive. Hiring physicians, as you can imagine, in Southwest Florida is difficult. We have been very fortunate in that our physicians are excellent. Most recent physicians trained at MGH and other major programs around the country, Mayo and so on. So we are adding physicians all the time. We're growing, our community is growing. We're going to match that growth with really high quality physicians. It's not inexpensive, it's costly. But then if you ask, is sickness and disease expensive? Yes, it absolutely is expensive. If we can get people healthier, that's what we want to do. Our goal is to help people live a healthier, longer, and happier life. And as we do that, it's expensive. Overall, NCH is fortunate to have community support, which has continued very, very strongly recently. And people do understand that this is a change, but we're doing it to take care of patients and not save money. We are going to be absolutely focused on fidelity, namely patients will go back to their primary care doctors or the people, their cardiologists, their orthopedists, whomever they align with. We've had a huge growth over the past year, 6% growth inpatient and 19% growth outpatient. So we don't even have the capacity to take on more patients. We're just bringing in more physicians to take care of that increasing demand. So we're happy to work closely with the community physicians, refer patients back, and keep everybody going. In this community, fortunately, and in Florida in general, we're lucky to be a growing place, and we want to continue with that growth and continue to serve our community as we have for the last 63 years, for the next 63 years. I'm Alan Weiss, and I'm happy to be able to share what our team of 4,800 plus folks do every day, and that's caring for you. That's our mission, that's what we want to do. We've got a great community, we want to continue that way. There's a reason we live 6 years longer than the average. There's a reason that cardiac disease and stroke are not our primary causes of death, but actually cancer is. As you live longer, something's going to happen. We have the ability and have had the success of helping our community be the #1 retirement community by a few different measures for the past few years. So thanks for all your help.